All right, I'm gonna give just a minute for people to enter the room here. All right, I'm going to start talking. So welcome everybody who's logging in to our session. This is an APDR roundtable session, and our topic today is teaching for the new oral boards. So everybody logging in is probably aware that in 2028, we're going to have the first round of the new oral boards for the radiology fellow group. And there's been a lot of discussion and a lot of preparation already, even though this is a few years down the road. And so our session today is to focus on some of the preparations that are going on or might be going on, anticipating this change. And we're specifically going to be looking at how we should all be preparing to teach the trainees who are going to be going through this exam. And so we have a number of people with us today who are going to talk about this topic, and I'll kind of introduce them as we go. I plan the session here with Shanna, who's going to speak in a little bit. And we'll start with Dr. Morgan, who is logged in, and she will give the ABR's perspective on this process. And then we'll move on to another group from Brigham and Women's who are going to share with some of the ideas they've had and some of the things they've been trying already in their program to get ready for the new oral boards. So that'll be kind of how it'll go. And then at the end, we'll have time for discussion and questions, and anybody's welcome to participate at that point and send us your questions, and we'll try to address what we can. So first, Dr. Morgan, who's joining us, and I'll give you the caveat that she's holding her granddaughter. So we're gonna listen to her expertise here. She's multitasking. She is from the University of Alabama at Birmingham. Dr. Morgan is the Vice Chair of Faculty Affairs. She is a former Vice Chair of Education and a former radiology residency program director. She's a professor in the abdominal imaging section and also on the ABR Board of Governors. So she has a lot of expertise here to offer us, and we're going to ask her to talk about the ABR's perspective on this new exam and what trainees and faculty might expect. And Dr. Morgan, are you still okay to?
I'm ready.
Awesome.
Okay, thanks so much for having me, everyone, and we'll see how this goes. First, I'm going to share my screen and try to find my talk for y'all. Okay, so hopefully you're seeing something that says ABR Diagnostic Radiology Remote Oral Exam.
Yep, we are.
Thanks. I'm really trying to focus on the candidate experience here. So I am from UAB, and thanks again for having me. I'm going to talk in my ABR hat first, but certainly I have ideas as a former PD. And I have to give attribution to Steve Simino, who is also a volunteer, long-term volunteer for the ABR, who is, as you'll see in just a minute, part author here. So these are my disclosures. I'm a long-time volunteer. I'm PGY 36, so I've been around the block, and I've had multiple roles through the ABR. Currently, I do serve as governor. When I was on the Board of Trustees as the DR Vice Chair, I led the charge for having this new exam come to fruition with all of our stakeholder groups, et cetera. So I'm coming at you with that perspective. I also need to disclose I took the oral exam, and I was an oral GI examiner, not every year between 2001 and 2013, but usually every other year. I am not paid by the ABR, have no financial disclosures. It's always good to start with the mission, but mostly I'm showing this slide so that you understand that we're talking a big test, an administration to about 11,000 folks for this DR remote oral. And if we look at compared to the old kind of what we're expecting to have for this new exam, you can see that compared to the old categories, we're only having 7. Ultrasound used to be its own category, but it's woven into the fabric of all of the other categories. For example, MSK, abdomen, breast, peds will have ultrasound. There are procedure-related content is going to be included in the areas, the categories of interest. For example, in the abdomen, we'll have things about liver biopsy. So it won't be its own category as well. So included in each area, we'll have those things. And also peds. Okay, I'm handing off the baby. Everybody take a look at my granddaughter. There's Emmy. Anna Grace, come get her. Thank you so much. Here's the bottle. Okay. Sorry. It used to be that peds might have cases that crossed over into GI, and same with nukes. Right now, this statement of PEDS content will be in PEDS, NUCs will be in NUCs, just makes that category will have, only NUCs or PEDS, and they won't stray into others like abdomen. Now, we know that we can't cover the entire domain of each category in this test. And what's important for everyone to realize is we are going to be sampling across each domain, but we're trying to evaluate the skills that have been difficult to evaluate on a computer-based exam. By that, I mean a demonstration of the ability to find findings, to detect findings and discuss a case, or to have a differential diagnosis and ranking of differentials. That's been tough to do on a computer-based exam. Also, recommendations on next imaging steps or procedures. And also, we're really trying to focus on heightened awareness cases. So when I think about the depth of what we're testing here, it's like if you get a great resident into your memo fellowship and they're going to do like moonlighting, internal moonlighting, cross-covering abdomen, they should be capable of doing that. So that's what we're talking about here. So cross-covering, finding things that are important and heightened awareness. Okay, as far as physics and safety and non-interpretive skills, if there are any questions on that, they'll be pertinent to the case content of those 7 categories. And there will be coordination. This didn't happen in the old exam across the categories. I'll show what that means in just a minute. We have decided, because of the time pressure of doing these categorical exams in 25 minutes, that there won't be any normals. In other words, we won't have somebody scrolling up and down just to tell us it's normal. So people can, we hope that you're teaching normal, that residents certainly can identify normal, but we won't be testing on normal. So this is where Steve Semino comes in. He created this hypothetical grid. And in this, I'm going to explain what I'm talking about with respect to coordinating the content. This is abdomen, MSK, and PEDS. Again, this is not a real test. It's just a facsimile. You'll see that there are subcategories for each category, and there are diagnoses. And this coordination of content will be if one diagnosis shows up twice on a form, like this would be a one administration, we'll remove one of those and replace it so that you won't be tested on the same exact diagnosis twice. Similarly, everything in orange is a cancer. So we're going to look at, well, this set of cases that we have for this examination is too heavy on inflammation or cancer, and we'll adjust there. You can also see the modalities will be tracked to test that level too. So that's how the test is being set up, just in case this helps you as people prepare. This was not done with the old oral exam. Okay, so if we look at what you experience, and so really people are really nervous about what's it going to be like. You can see that this is going to be a remote exam. We're not going back to Louisville. That before there were 11 categories. Now there are 7. The length of time, 25 minutes was when like the bell went off. I don't know how many folks on the call took the orals. You probably remember there were 2 sets of bells. One was like the warning bell, and the other bell was like you got to get out of the room and go to the next one. For the new test, it's 25 minutes set for each category. And because we are already doing remote oral exams in the other disciplines of the ABR, so IR, RAD-ONC, medical physics, we know that the transition from one remote examiner and examinee to another takes about 10 minutes just to make sure it happens. So that's why we've built that in. The length of the test for the examinees will be about 4 hours. It used to be 5. The number of days we're going to do this, you'll see why in just a minute. We can only do 1 administration a day instead of 2 a day like we used to do. And these things over here, category meetings, in a minute you'll understand more about that. There's going to be the same number as days of testing. And again, there is more standardization. We're trying to mitigate subjectivity by having one case set with scoring rubrics for each administration. And again, we're coordinating the cases, which wasn't done before. So if you'll just take a look at this example of a single panel. So 7 candidates will be examined in each panel. There will be a simultaneous start across the continental United States. So you see we'll start at 10, where it's anticipated that we're going to start at 10 a.m. on the East Coast, 7 on the West Coast. And that's why we can't do 2 a day, because the East Coast will finish up way late for starting a new test. There'll be identical case sets shown within a particular category each day. In fact, we're even projecting that the order will be the same for people, trying to, again, to mitigate subjectivity. Each category will be scored for the candidate at the end of each 25-minute session. So the examiner will assess, based on the scoring rubric, what happened and make that scoring decision. The recovery period that you see here at towards the end is in case there's a technical issue with one of the exams. We've been able to really get almost everyone else who's had an oral exam by the ABR in the past several years completed on the day of, because we have that if something happens in one category where, or even up to two, where there's a technical issue that results in the assessment not going all the way through, we can catch that up. So the candidate just has one experience one day. And then you see the categorical meetings. This is when all examiners in, say, PEDS will meet together and talk about the cases that day. If one case really tested poorly on everybody, they'll take that into consideration in the scoring. And finally, the panel meeting is where everybody who's on a panel, so the one PEDS examiner, the breast examiner, the chest examiner, the abdominal examiner, et cetera, that saw that one candidate, will all talk about their experience with that candidate. And that's when the final score for pass or fail will happen. So if you look at what the candidate experiences, and let's just pick candidate A, they will spend their first period with Dr. X, second period with Dr. Y in breast, next period with Dr. Z in chest, etc. Okay, so they will just float down, and then candidate G would start with breast and wind up, you know, in a different place. And as far as what does it look like, we're actually trying to make a video with this. And so you'll see that here's me, and this is Derek's son, who played the role of a candidate. And this is what it's going to look like for folks. And I might introduce myself and say, okay, here's this patient that had right upper quadrant pain, incidental finding, was seen here. What do you think is going on? And he'll describe the findings and say, well, I might get an MRI to see that better. And then I would say, okay, here are the images from that MRI. And then he would go on to discuss the case. So that's kind of, and this is obviously live. It's a video chat, basically, like we're all used to doing now in Zoom. Now, people have asked about what do we mean by rubrics? And again, this is just an example. These aren't yet made. This is all the infrastructure and everything is kind of going into play right now at the ABR. But for the mock video that we are creating, I had to go through this exercise. So you can see that we will have the images. We'll talk about what we expect the candidate to have said, pertinent negatives, etc. If they recommend getting the next test. And so these will actually be available, but they're not, again, this is just a mock-up. The item writing committees, the people who will be making up the content for the new DR oral exam, are not yet formed. The sample rubrics are being worked on by the trustees right now, and they'll be provided for all 7 categories. They'll be available on the ABR website. You guys will have access to that so you can see kind of what we're talking about. Again, we are making a mock DR oral exam reenactment video, and there's already one available for IR. So I'm showing a QR code here. If y'all haven't seen this yet, I'll make it bigger on this. This is my last slide, talking about conditioning and conditional passing. So for the new oral exam with 7 categories, a candidate may fail up to 2, still pass the test with a conditional pass, which means they have to come back and take those 2 areas that, or 1 or 2 areas that they conditioned in at a later date. Before it used to be 3, but we're anticipating that same phenomenon. So that's important to, you know, let our candidates know. So with that, I am going to stop sharing, and I'm happy to answer questions now or after everyone talks and be, you know, a participant in the panel, whichever y'all prefer. But thanks so much for your attention. Thank you for allowing me to feed my grandbaby on time, and I'll pass it on to the next speaker.
Thank you so much, Dr. Morgan. We have a few minutes now if anyone has questions for Dr. Morgan. Otherwise, we can proceed. But I don't know if I'll give just a minute for anyone to write in, or if anyone else on our panel has questions. But
I had a question.
I want to know from y'all about what to do about teaching them. Go ahead. Sorry.
I was just wondering, so in the example you showed, it seems that both the candidate and examiner can see each other. So, okay.
Yeah, so there are thumbnails where you see the faces just like you would on a Zoom where someone is doing a presentation, but the vast majority of the screen is the images. And some, you know, there'll be scrollable images, there'll be ones, there are ways to magnify, just like currently exist for the core and cert exam. There's manipulations that the candidate can do to really fill up the screen. But those thumbnails, just teeny tiny. You know, we've talked about back in the old days, the examiner sat next to or behind so that you couldn't really see their face. And so the training of examiners will be, you know, just to try to look kind and placid, but not kind of give indicators of things going right or wrong. So that's going to be part of the training.
Great, thanks.
yeah, it sounds like there's a lot of effort going on for coordination and standardization, which seems like it's a good thing for setting this all up. So thank you so much for explaining that. It's really good to hear, I think, from the teaching perspective. All right, well, we will move on to our next segment then, which is to take that information of what we're expecting and then to try to figure out how training programs, and these might be residency programs or fellowship programs or both, are going to try to help prepare trainees for this. And this includes both knowing what the trainees are going to go through and then understanding how faculty might play a role in this and how we can help prepare faculty for this experience. And so two of my colleagues here are ready to take it away. And Shanna, I'll hand it over to you.
Perfect. Thank you. So my name is Shanna Matalon. I'm one of the associate program directors at Brigham and Women's Hospital in Boston. And I have here Dr. Agatha Stanek, who's one of my colleagues in the abdominal imaging division. And she's going to be sharing with you what mainly she has put together to prepare our residents and eventually our fellows to take the oral board. So Dr. Stanek is originally from Ottawa, Ontario, where she completed medical school. She completed her diagnostic radiology residency at McGill University and an abdominal imaging fellowship at MGH. She then went back to Canada for a few short years and missed Boston so much she had to come back. And so she joined us this January, and she's been really integral in organizing our curriculum. And so we are very indebted to her. And who better to teach for the oral boards than a Canadian, right? So they've had it all along and they never stopped. So with that, I'm going to let Agatha take it away.
Thank you, Shanna. And I will add that your mentorship has also been extremely appreciated since I got here. So thank you for everything. So I'm going to share my screen here just real quick. And we'll get started. So I'm going to be talking to all of you today about the Brigham experience so far with the oral boards. And I've left my email here at the bottom for any questions and if you want to reach out. So first thing we'll talk about is just an overview of the oral boards prep plan and the curriculum here. And then we'll kind of get into a faculty development workshop that we've actually implemented here so far in the last few months. And from there, we'll move on for suggestions for implementation. So in terms of the overall approach here, we have a two-tiered approach. So for the residents, this involves several things. So starting with R1, they do get a conference in July on how to take a case. So an introductory program that teaches them how to describe findings, how to provide a differential diagnosis and management. But the main bulk of the lecture is really centered on how to describe their findings and build that vocabulary. As things progress, they also will be getting these monthly subspecialty oral board teaching sessions, which we'll get into shortly. And they've already had one actually at abdominal, and yesterday they just had their interventional radiology one. From there, we're also going to be implementing an annual mock oral examination. So that's going to be a little bit longer with all the subspecialties, which will be performed usually in the spring. And that's something that we're currently working on. And then for the R4s, we're hoping to implement twice monthly oral board prep sessions, sort of closer to their actual examination date, which may involve them being done both during and after hours, depending on what the need is. From there, in terms of the two-tiered approach, we also have the faculty who we've been targeting as well. So we've prepared a faculty development workshop that has been available over the summer. And we've also provided them with some best practice guidelines, which I'll show you guys as well shortly. The only question we sort of have that's still up in the air is how to implement most of this for the fellows. We have many fellows. There's about, I think, at least 70 per year. And we don't really have a plan yet. So this is something we're hoping to maybe discuss and think about for the future, is how to integrate the fellows into the curriculum and preparation, as the exam will be done during the fellowship year. So how to take a case conference, as I mentioned, is given from July and August, and it's kind of like a boot camp. And from there, there's a part 2 series as well the same day. So that's more of a low stakes conference where a resident is asked to describe the findings and another resident faces the other side of the room. It's not evaluated, and so there's no real pressure, but it's just to get them into the whole system and used to being able to do this. We also have some monthly subspecialty oral boards plans as discussed. So we've already given our abdominal division and the angio one that happened yesterday. And these are basically facilitated by our resident liaisons who usually help facilitate a resident's rotation and evaluations. But this isn't necessarily their responsibility to do. So we open this up for any of the faculty to partake in. So we also do have a separate one, as you'll notice, for ED, and we do have, this is specific to the Brigham, but because the ultrasound department is sort of its own area, we do have a dedicated session for that as well. In terms of the mock oral exam, so this will be within 2025. We're still hashing out all the details, but we'll be incorporating sort of other more seasoned faculty as well to partake, depending on interest. The monthly oral board prep, as I mentioned, might replace resident conference depending on the need, and it's flexible at this point. So we are open to doing it in the morning or in the afternoons. So now we're just going to get into the workshop that we had for the faculty. So this was about less than an hour, and it was performed at various times of the day. So we had one that was done in the morning at 7:30, and another one, the other two were performed at lunchtime. And so we held a total of 3 workshops that were both online and in person. And we also provided a food budget for everyone to encourage participation in person. We also created a recorded version of this after the last workshop for on-demand review for those who were too busy and were unable to make the selected dates we had available for everyone. And then we also had an email to sign up for the workshop that was sent by the Vice Chair of Education, who was very involved in helping to propel this and sort of make this a mandatory component for everybody. So that was really helpful as well in getting things rolling. The preliminary results of our pre-workshop survey are great. So we had about 43 participants partake so far out of 120 faculty as of early September, and 84% of them had completed the pre-workshop survey. So one of the first things we had asked was just trying to assess, had you taken the oral boards yourself as part of the certification process? And most faculty said yes, so 61%. From there, we had asked, how familiar are you with the changes and updated format of the new APDR oral board examination for 2028? And most people had indicated not at all familiar or slightly familiar. We also had created several questions in the pre-workshop survey centered around confidence. And there's several little points here that we tried to explore. So one was about the ability to manage their time for a case, how confident they felt about redirecting somebody who was struggling to get through a case, evaluating their performance or getting through the case if they're struggling, or are they able to prepare a case and select an appropriate case for a conference. And so this is something we also looked at. So 17 participants completed the post-workshop survey. And after this workshop, it was found that 100% were either moderately or extremely satisfied with the workshop overall, as well as to having access to the on-demand resources and recording provided. So when we asked this faculty how familiar they were with the changes and updated format of the examination after the survey, or after the workshop, I should say, they had indicated moderately and extremely familiar compared to the pre-survey, which is indicated here at the bottom. So in terms of confidence levels, 100% moderately or extremely confident was indicated on all items. There was just one person who felt still slightly confident to guide a resident through taking an unknown case. This is an example of some of the PDFs we created for best practice guidelines. So I won't be going through this in great detail, but here we have one for creating oral boards cases based on subject matter and image selection, format, and just how to optimize the images for presentation. And then we also just created a sample grading rubric just to encourage everybody to be less subjective. And so that was something that we had created. And so now I'm just going to briefly touch on some salient points from our oral boards faculty workshop. And so let's just dive in. So we kind of thought about this in 2 different ways. So an informal and formal way of approaching all of this. And something that's really important to consider when we're selecting cases, and something that was highlighted to the faculty, is to consider the following 3 pillars. So the modality you're selecting, the subject matter, rotation, subspecialty, and also case difficulty and complexity. So, it's important to be mindful, for example, of a modality that X-rays, ultrasound, certain modalities are usually taught earlier rather than, for example, MRI, where residents don't necessarily get that exposure right away. For subject matter, rotation, and specialty, this obviously varies by program, but for ourselves, I'll get into that shortly. And case difficulty and complexity. So something to consider, somebody who's much more advanced and closer to graduating can probably put together different modalities, and an example of a complex case or a syndrome with different parts of the body being assessed versus somebody who's just starting out in their first month of a rotation. So in general at the Brigham, we had some specific suggestions based on the curriculum. So MRI, we generally discouraged being presented unless it was an R2 or above. And same thing went for pediatrics, just because they're not exposed to it right away. For IR procedural related cases, so angio and breast procedures are performed in their first year. So this is definitely testable. But it's interesting that, abdominal procedures are actually performed later on. So that was something to consider. And we did highlight the fact that physics can be implemented throughout because the residents are exposed to a course quite early on. So this is definitely highly encouraged regardless of resident training level. We had also provided the staff with the slide and QR code to a free resource online created by residents on RSNA, which basically breaks down a top 10 must read by subspecialty, and then also goes further than that to touch on resident year, and then basic and intermediate level pathologies and important articles, which are very helpful. So in terms of case selection, we were focused on learning objectives. So we were trying to encourage the staff to think about, what are you trying to test for this case? So what's the main salient point? Are we trying to focus on the origin and describing the finding? Or is it more about providing an important differential diagnosis versus an AMP-Meany, and then next steps in management as well? For our case creation, we then went on to touch about the format, image selection, and content creation, which wasn't an absolute thing to have to follow, but more so as a guide to help those who hadn't been exposed to this previously. So in general, we suggested people have one question stem on a slide with selected images, 1 to 2 slides, and then focusing on the finding, the differential, and further management as suggested by the ABR. And then we wanted to, for image selection, really encourage optimizing good quality images. So those were performed at our institution, avoiding distractors or where there were many artifacts, unless that was something that was being tested specifically. And then we wanted to make sure that images, it was very clear, for example, that, a clause sign is demonstrated here. So it's very clear where the finding is originating from. So, that there's no confounders such as bowel or other adjacent structures in this example. And then window level as well. So thinking about what kind of windowing is used to highlight an intended finding, which just leads to, for example, if, you wanted to look at the bony lesions, you would use bone windows, etc. And so for image presentation and annotation, it was important to think about how the images will project for the resident taking the case. So, max of 2 rows of images in general, keeping them similar in size. And if desired, they could provide some parameters just in terms of the sequences and such. We also had some specific modality suggestions. So based, multiple views and, using a scale and sending clips when we're talking about ultrasound. And then for CT, just making sure we had the appropriate windows as mentioned previously, and for MRI as well, when relevant, just having the appropriate, for example, DWI and corresponding ADC image. So in general, we tried to mimic as much as possible the mock oral exam and thinking about how much time to give the residents in terms of taking a case. So allowing them about 3 minutes or so, up to 5 if it's somebody who's very junior, and giving them a couple minutes of feedback afterwards, and then providing some discussion points and opening the floor up to everyone to ask questions. And we also did plan to avoid asking normal cases. So we wanted to optimize the learning environment because obviously this is something that's very stressful. Having done this myself, I can definitely attest to that. And so, it is a very daunting experience, and there's concerns about shame and humiliation when you're trying to take a case and you're on the spot and your IQ tends to drop. So it's really important to encourage this concept of psychological safety. So being able to take risks, and even if you're wrong, and that it's a safe space to do so. And the point is not to be right, but really to be able to learn and to prepare for the exam. So this was an article focusing on the ABCs of psychological safety that we had touched on. So talking about how this is a space for learning and modeling that at the beginning of the session to the residents and stating that explicitly, and then being curious. So avoiding judgment when you're the staff giving cases to residents. And then at the end, collaborating and being really encouraging that they're participating is super important. So again, progress is not perfection. So when we cultivate psychological safety, some things we concretely had provided in terms of what can be done. So no recording of somebody taking a case, no phones or other distractors, and then really setting the expectation that everyone should be respectful of the person who's on the spot. During the case, it's important to stay attentive and avoiding your own cues as the staff who is facilitating the session. And afterwards, validating their emotions and giving them some formative feedback, but also just encouraging them and being supportive of the fact that they were on the spot. It's also important just to make sure that the other residents or anybody else in the room for that matter just isn't having a conversation or even trying to discuss the findings and testing each other. And keeping them engaged when they're not taking the case is something that has been encouraged. So even a paper and pen, just testing themselves on the finding, the differential, and the management if they're not in the hot seat. We really encourage punctuality and avoiding disruptions as mentioned, and then no interruptions by anybody else, but saving time afterwards for any opening the floor for questions, of course. So now we're going to talk about a little bit on evaluation. So we did create a brief example of a rubric just to help staff stay focused and be less subjective in their own assessment for these conferences. And they're really just centered on the important points of the ABR itself. So firstly is the description of the finding. So the correct finding is made, what a few descriptors, and then the location, as well as any pertinent positives and negatives. We also have a section on a differential diagnosis. So do they make the correct diagnosis? Is there a good differential diagnosis, and is it ranked appropriately, where appropriate? And then management as well. So did they recommend the correct referral to someone, labs, that sort of thing? And we also have a little section just on professionalization. So is it being taken seriously? And just circling, pass or fail at the end. So in terms of, providing feedback, things we had touched on for the staff of, some common challenges and how to handle that. And this is again centered on the finding, the differential, and management. So when someone is sort of missing the mark completely on the finding, just reminding them about the question stem, so asking them to reread it, or just redirecting them as well, depending on their training level. There's also, with the differential diagnosis, if, the resident blanks and is unable to generate a differential, just reminding them to give one, or what, stating things like what it is, or to please provide a differential diagnosis can be helpful. And if it's completely incorrect, asking them to confirm that that is their final order. Regarding management, so, again, if the resident is unable to think about the next steps, encouraging them about, who to consult, what are your next steps can be helpful in those cases as well. So safety concerns for the patient, super important to make sure that, something like a pseudoaneurysm isn't labeled as a mass and that the resident says there's a biopsy that's warranted. And if, they're really deciding that that's what they want to proceed with, just confirming that that's the answer and proceeding, and not showing any facial expressions, verbal, nonverbal, super important. So suggestions for implementation. What's worked well for us so far at the Brigham is having somebody who's sort of focused on preparing the curriculum has been really, really helpful. And then, having somebody who's available to answer via email any of the questions for the resident liaisons and those who are giving cases. We've had a lot of support as well from the PDs, the Vice Chair of Education. That has been really instrumental. And then minimizing the burden for all the faculty. Everyone's really busy, but providing this workshop in, times that worked for everybody online as well was very, very helpful. And then just having a slow rollout, so not asking for, a conference to be prepared with not enough time, super, super important. We've struggled with faculty engagement for the survey so far. That is something that's worth mentioning, and resident engagement as well. So some residents being a little bit more anxious than others, but it does seem like they're slow to warm, but it's starting to move in a good direction. Subspecialty mock orals. So something to consider is perhaps having other rotations assessed earlier than, for example, interventional radiology. And also something that we're struggling with is how to incorporate physics into the stations. So if you have any questions or are interested in having this workshop done at your institution, please feel free to reach out to me, and I'll open the floor to any questions. Thanks so much.
Thank you, Agatha. I've been sort of trying to answer questions as you go along, but perhaps you may have some additional thoughts on these issues. So one was about with all the time constraints of our academic faculty, how do we motivate and incentivize faculty to devote time to this process, which of course is additive to the time that they're already devoting for core exam preparation and et cetera. You're muted.
I am muted. Thanks. I think just it's really important to have as much help, and it's a team effort really. Having a lot of support from the PDs and the Vice Chair of Education for us has worked really, really well. And as sort of touched on, the workshop that was available during working hours, but also having it on demand for faculty to review at their own convenience, having it not too long and broken up into smaller segments as well, something that's easy to follow. I think that has been very helpful.
I think I didn't type this into the answer, but another thing that we've thought about is just like having a slow rollout. So this year we've only really started with this introductory session for the R1s, and then these monthly 90-minute sessions, which each division's only responsible for one a year. So it's not a significant addition to what they already do for resident conference. And we've made it very clear that although the resident liaisons, who for us are faculty, individual faculty in each division who sort of oversee resident education, are responsible for making sure it happens, they're not the only person who can teach the session. And so they can recruit cases from their colleagues. They can even recruit a different colleague to give the session, or the session can be divided into multiple faculty giving it. So I think just trying to reduce the burden on any single faculty member can help.
And so, Agatha, that was awesome. I have a question about how it seems like right now, and at least in my head, like it's almost like we're treating these as separate entities. There's the whatever we've all been doing for resident conference and core exam preparation, and then like it sounds like you guys are kind of slowly building up these sessions that are like oral boards related. So, R1 sessions, how to take a case, and then we have like these mock exams, and we have, specific oral board preparation. How do you eventually plan to merge them? Or do you, at some point, are these kind of like the same so that it's much more incorporated into the regular conference? Like, how are you guys kind of dealing with that? Because it seems like suddenly we've got so much to put together in the same amount of days. Like you've got to prepare residents for the core and for the oral. Like, how do you picture merging them eventually when we get closer to the years that we're doing the exam?
So I think it's just important to start as early as possible, just because like any learned skill set, it just takes a lot of numbers to get really comfortable. And especially, I know the day of, they're going to be very nervous. So it, gets to a point where it's just a reflex. They don't have to think is very helpful. Having this on a monthly basis doesn't take away from their other teaching experiences either. And we do provide some teaching points as well, centered around the actual pathology, around the oral boards case. So it's not just centered on the description and the differential, but there's usually a teaching slide that's provided as well. So there is some content teaching. So that's one thing. The spring mock roll boards, that's only done once a year, but again, that's just getting them ready for that format. But overall, they still have a lot of content and theory-based teaching in the current curriculum.
Mhm.
I'm not sure, Shanna, do you have anything to add?
No, I think maybe I'm realizing now that maybe we weren't clear that the 90-minute sessions are actually part of resident conference. So it just, it's built into the regular conference schedule. As is the like intro to how to take a case. That's just part of their like normal conference now. It just replaced something else, I guess. And Agatha had had the slide sort of like formal versus informal. Like the mock orals is like the formal version of how we're preparing them, but everything else is more informal. And we've certainly encouraged faculty to feel free to include more like oral board style case sessions in their teaching conferences. And as Agatha said, those always include a lot of like content teaching in addition to case taking, I guess. So I think, as we get closer and closer to the boards right now, the second years, it's still far off for them. So I don't think they're as motivated. And I think the faculty also, this is a slow roll. So I think more and more as we get closer, that will become a more prevalent form of teaching. I remember when I started residency, the current fourth years were the last class to take the oral boards, but we were still very much teaching all conferences towards that exam. And it was still a great way to learn, even if it was for the core exam. So
I have a question, Agatha, and this has to do with the psychological safety. The 90-minute session sounds like it's the entire residency. So there are first year, second years, third years, and fourth years. And the cases that you, I mean, it was an amazing presentation. Thank you so much for it. You're giving different cases to different level learners, which makes a whole lot of sense. I do think it's really important to model. So for the young ones, younger, and I mean younger radiologically speaking, to see what the more experienced ones are doing. So there's an expectation of how to really take a case, but there has been some talk about we should separate everybody out, and there are different schools of thought on why that might be good. But it sounds like there is some attention based to paid to the early learners of just taking a case in general, like introductory things that we all tend to do. But can you talk a little bit about how that dynamic has been so far in the two you've done?
Sure. Yeah, absolutely. And it's interesting too, because when I was a junior resident going through this, I remember you would just sort of sit and watch the senior take a case and you go, wow, that's amazing. That's the goal. That's what you want to get to. But unfortunately, they don't have that now, right? Because there is no senior, anybody who's been doing this. So it's definitely interesting, which is why I think it's so important to really emphasize the point that, you understand you're not here to judge them and you're just here, you're trying to help them. This is about them developing this new skill set and it's going to come. So I think that is really, really important and encourages getting people to take a case. So, even then it's personality dependent, I suppose, but some were more willing than others and just wanted to sit out for the first one. And so I wasn't, really pushing it. But, we had somebody who was okay with taking 3 cases. I think they got 1 of the 3 diagnoses, but the fact that there was that enthusiasm and willingness to participate was really great. The first couple of cases I had shown them, it was kind of, it was like slow to warm, but after that, there was a lot of actually great questions. So they were very enthusiastic and were asking wonderful questions. Are we going to get normals? Are we going to, do I have to describe each sequence in detail? Things like that. So that was all very helpful. And as, after a couple of cases rolled out, then there was less of that anxiety to take the case. I just asked them, who's done an ultrasound or who's done fluoro, who's done a CT rotation, who can take this. And, there was less of, trying to pull teeth, but there was just that willingness. And they said, oh, I can take it, So I think it's also, it's really important to help them, to emphasize the fact that, I'm just taking notes and everything. They're not getting graded on this. They're not going to fail. This isn't going to their program director. There's no repercussions from this session. So I think that was also really important to mention.
Great. I did have a question that came in. I don't know if it came to me or to everyone. And the question was, how much will the new oral boards cost the candidates? And the answer right now is it's the same fee. It's not, I mean, if the ABR has a lot going on with respect to IT to pull this off, we've again been doing remote oral exams for the other disciplines, rad-onc, medical physics, and IR. The scaling and really what we need to properly show the DR cases is a little bit different than those other disciplines. And that's happening right now. So it's not anticipated that there's going to be like, oh, this will be $2,000 more or anything like that. Right now it's the same cost as what we're projecting.
Great.
There was another question, Dr. Morgan, I don't know if you are aware of this or anyone else, that there was a question about whether there's a national database of cases, like a resource, that would be available so that each program didn't have to reproduce all of this, I guess, preparation material. Do you know anything about that, or does anybody?
There is not one at the ABR. I don't know of, there's been a lot of push through RSNA about case banks and sharing between, I'm not sure that any of those have taken off specifically towards, getting people prepared. And again, the content, we can all step back and say, well, I don't know what happens when you check out your resident CTs, but there's a tendency in the world of, and this is me, not ABR talking, it's me as an attending, as a former vice chair of education program director, in the world of structured and standardized reports, to go down a checklist instead of thinking about what is the clinical question and thinking about it from a disease specific state. I think that's really important as a daily practice to get ready, not only for your future practice, but for the ABR exam. Instead of saying lung bases check, liver check, whatever, it's like, okay, this is a cirrhotic patient. I know the pretest probability of HCC is that. And then, so my checkouts are kind of like mini board exams. So I applaud, like, we want to definitely prepare people. The whole question about if we prepare them during residency, will they forget everything by the time they're fellows, and what do we do for fellows? That's for another roundtable and a whole other group discussion. But like, if this is built into the culture again, and then all the badness about, you know, not wanting to take cases and stuff is more normalized, we just do this every day, I think that'll really help people be successful in life ultimately, and definitely on this test.
I want to say, and this again is my own memory and nothing official. I'm not involved with the AIRP, but I seem to remember some discussion perhaps from the AIRP that there was going to be some sort of oral review or some sort of interactive review potentially geared towards this, sort of like an interactive practice type thing. Again, I that is not official. I know. I think there's a lot of education people logged into this, so I would just, I guess, encourage you to look for that, because I don't want to misstate. But I thought that I had heard potentially that was going to be an opportunity, and that would be a pretty centralized resource that a lot of residents participate in. So that would be something to watch for if that comes to fruition too.
It might also be worth having individual programs just look into what their like PACS IT offers. So for example, we have Visage and Primordial, and at least in abdomen, we have a daily case rounds. And so people will put in cases and usually put like a quick blurb about what the case is about. So that's like a quick repository of cases. We also have like a search function in our PAC, so you can type like a specific diagnosis. It's not perfect. Sometimes it'll give you the negative cases, but there are, you know, workarounds so that you can try and find if you have a specific case that you want to show. It's, again, still some activation energy, but, you know, optimizing your IT can decrease that a little bit. So if there's a way for your division to like have some sort of shared list of cases that you can start to build a big encyclopedia of cases.
And then what will you do with it though? Use it to make mock oral exams? Or like, the thing is culling and cultivating and managing something like that, and also trying to get it right to not have too many zebras that are super interesting and we all think they're great cases, but they may not be appropriate for testing on an instrument that's looking at competence.
Yeah. Yeah, no, that's definitely true. I think it's just, if you have an idea for a case you want to show, it would be one way that you could find one, but it would be nice to have I think Agatha's suggestion of the radiographics, potentially the articles. And I think also, I believe the APDR put together these core rotation guides. I think they have them for all R1s. I'm not sure if they have more senior rotations yet, but it does have some suggestion of like what content is expected for them to know. So that could be a good guide also to help you figure out what kinds of cases to include in your review sessions.
I have a question, and it seems like there's going to be a group of faculty that have never taken the old oral exam, who I would assume would be pretty engaged in some sort of development, you know, process to learn what this was like and what are the expectations and how do I do this. And there's a pretty large proportion of faculty who have maybe been oral board examiners or who have gone through that themselves, and they may feel like, hey, I already know all this. I've been through it. I know what to expect. What are the things that group, the more senior group, should focus on that might be new? So there's some new logistics, it sounds like, and there's kind of a new process. And so there are things that you could say about how the categories, you know, the subspecialty categories are put together and exactly how the format is. But in terms of them actually teaching or giving cases, is there anything new for those faculty to focus on as far as their method, or is it similar to what the old exam was like?
I think when preparing like for a case conference or whatever the teaching conference is called where you're doing this, that probably they don't need to change much of what they did before. The particulars of how the exam will run, you know, is not known. So we can't give hints about, well, you know, if you say these 3 things right, then that should be a positive score. And we don't have any of those logistics. So there's nothing really to retrain on insofar as teaching you know, how to take a case and do that. So people have different styles. You can be, you know, give hints and give, these were just, Agatha's was spot on with, you know, always being kind, respectful, positive about things, not, you know, just trashing people in a hot seat conference like happened back in the millennium when I was going through it. But when it comes time to actually have volunteers, we're going to need an army of volunteers to do this and actually administer this remote oral exam. People who have their concept of what it was like before will be retrained to what it is now, and those that have never done it will be trained to what it is now, and that will come together. But I don't have any advice, and there really is nothing that I would say to do differently other than to just keep it real and do it in the service of positivity, constructiveness, and that's what people respond to. I found another question in the chat, if I might just answer it, and I'll read it first. It says, I saw the eligibility period for the certifying exam is 6 years from the completion of residency. That is true. That's how it always has been. You have up to 6 years. You can take it, you know, every year for 6 years or whatever, or not take it for 5 years and then take it once, whatever. Says the question then goes on, are residents who graduate able to take the certifying exam during their fellowship year rather than wait after fellowship completion? So right now, in the current paradigm of taking part 2, which is the certifying exam, right? Part 1 is the qualifying core exam. The earliest you can take it is 15 months after graduation, which puts it 3 months after the end of a fellowship if you choose to do one, or 15 months after graduation. And then you have that 6-year period. For the 2028 new DR remote oral exam, it is going to happen in the year following graduation. So it will be happening in the fellowship year as the first administration. Again, this is something that is, you know, everyone wants to take it first and be done with it. But you really don't. You could wait 2 or 3 years in practice and have a general practice and take this and probably do pretty well. And people do that in other specialties, like in surgical subspecialties, right? They have to have a certain number of cases before they can even sit for their orals, and things like peds, critical care. They're in practice 3 years before they take it. So the ABR right now, the first year we do this in 2028 has to be in that spring, because the 2027 last certifying exam, as we know it now, will be in the fall. But there may be a time when there's a spring and a fall administration. So you can choose to take it early in your fellowship, later in your fellowship, or after your fellowship. It's up to the individual. And the more we can normalize kind of those choices, you know, everyone's so nervous about making sure everyone is successful here. On the education side, it's certainly on the candidate side. You know, we have a little bit of room there to get it right. So yes, you can take it anytime in those 6 years. And there's a comment here. Did y'all see the one about, I've asked residents from different programs their feelings on taking cases in a hot seat conference, and overall the response is favorable, meaning they want it. So I guess my question is for the people who aren't taking the oral exam in your residencies right now, Agatha and Shanna, when you have your 90-minute conference, are they wanting to take cases? Because we have advisory committees for the ABR. We have residents, fellows, attendings that sit on those, and they are our stakeholders that give us information on their thoughts and about the testing processes. And they're like people in fellowship saying, oh, I wish I could. Now, whether they're just saying that, you know, and they really are thankful that they don't or whatever. I mean, I'm asking, how has that been received by your more senior residents who aren't going to be taking this?
In my experience, there's been a general sense of relief that the senior residents that they don't have to do it. But like I said, you know, there was a difference between the first and second session. The first session, there was a lot more, you know, shyness and sort of hesitancy to, you know, be on the spot. But once you know, that the first few cases happened, there was more and more participation and just general comfort and recognizing, you know, seeing your colleague, they might not get a case, the world doesn't end, and what ensues afterwards, I think, just knowing what to expect during the feedback period, and having that time to ask questions, I think is really helpful too.
Great, thank you for that. Sorry, I don't mean to dominate. There's another one about, are there plans to make a core exam oral? And no. We're happy with the computer-based exam for that initial qualifying exam. It covers all the domains, it tests knowledge, it gives us definite information on how people are progressing in residency and how developed their knowledge base is. The oral boards is to take it to a different level and assess things that we were not able to do with a computer-based exam twice in a row, if that makes sense. So no, there's no plan to change for the core or qualifying exam for DR.
Perfect. Just another comment about the APDR guides in the chat. So I put the link and someone had suggested that they are downloadable, so you can sort of personalize them for your own institutions, but it's a nice starting point. And I agree. I think that's great.
Well, I think we've had a great discussion today. It was really great to hear about some specifics of the new oral boards from Dr. Morgan. That was helpful as we're forming our plan to try to support the learners. And our colleagues from Brigham and Women's seem like they're way ahead of the curve here on setting up a curriculum and a plan and a faculty development program for their group. And I think that's very helpful to the rest of us as we're shaping this over the next few years. So we really appreciate you sharing that and having some data to show us. And we really are glad to have all of you here today. I will say that we can end there unless there's any final questions, but thanks to all the panelists for participation and their presentations, and thanks for all of you for joining. And if there's any questions after this, or you want to email any of us, we just let the group know, and we'd be glad to talk about it more. It's certainly something on all of our minds these days. So we appreciate your participation.
Thanks for the opportunity to share.
Thank you.
Absolutely.
Thanks for
Thanks
having
to all of
me.
you for coming. Yep. Have a good day.
Thanks, you as well.